ladies and gentlemen, my name's Sophie Scott. I'm the medical reporter for ABC, and I'm going to be your host for this panel discussion. So, as with other sessions today, we want this to be interactive. So we want you to be getting on the app and asking questions. I'll try to get through as many questions as I can in the session today. There'll also be the opportunity for you to ask questions from the floor as well. If you're on Twitter, hands up who's on Twitter and Instagram. Okay, excellent. So if you are on Twitter and Instagram, please tweet about this session, take photos. The hashtag is ABF19, and if you can include the IHACPA handle, and my handle is Sophie Scott and the number 2. If you could include that, and I'll try to retweet things as we go. And now we've been sitting for a little while, so while I introduce all our amazing panellists, I'd like everyone in the audience to stand up. We know prolonged sitting's bad for you, and we can also, that means you can give our panel a standing ovation that they deserve. So, I'll start up the end. We have Professor Ewan Wallace. He's the inaugural Chief Executive Officer of Safer Care Victoria. He's an academic obstetrician and gynaecologist by training. Give him a round of applause. We have Professor Amanda Walker. She's the Clinical Director at the Commission on Safety and Quality in Healthcare and a specialist in palliative care. She teaches communication and development at the Western Sydney School of Medicine. Give her a round of applause. We have Dr. Craig Margetts. He's the Director of Medical Services at Redcliffe Hospital, Metro North Hospital and Health Services. Give Craig a round of applause. We have Cathy Jones. So Cathy is the National Quality Manager for HealthScope with 25 years experience in public and private hospitals, and she hosts a very popular podcast called No Harm Done, which I suggest you all subscribe to. Give Cathy a round of applause. And last but not least, we have, we've gone through everyone. Alasdair, there we are, my first panellist. He is a physician from Tasmania, based in Launceston, working in private practice, and he's chair of the Clinical Advisory Committee to IHACPA. So give them all a big round of applause. Thank you. Now, you may be seated. Thank you. So we've heard a lot today about the theory of activity-based funding. We've heard a lot of theoretical discussion. What we're hoping from this session is we'll hear some more of the practical applications of how it actually works on the ground and the clinical applications when it comes to hospitals. So let's start with the good news. So when it comes to activity-based funding, let's talk about the benefits and where it's working well. So let's start with the benefits. Craig, what do you see as the benefits for ABF?
Yeah. If I boom.
That's good. Nice loud voice. Yes, so Craig?
I started with case mix and ABF in 1988, which is technically impossible given that I'm only 35. And looking at that trajectory, the main thing it's done, I think, of benefit is provided an ability to have a conversation. It's the conversations with administrative staff and clinicians, with funders and patient level working at the coalface that I think has been the main benefit over the years. And I've seen that really make significant changes both in quality and in financial value.
And what about our other panellists? So, Alasdair, what would you say about the benefits? Where have you seen it really beneficial?
In my practice and in my role as running a department, the improvement in data has really been on a very steep curve, and as a result of that, suddenly I have clinicians who wouldn't have thought about in terms of activity, wouldn't have thought of in terms of that sort of data, coming to my office wanting to interrogate data, looking at their rates of various things, including their rates of complications, etc. So there's been a real mindset change amongst my clinicians that I work with respect to the utility of data in planning how they perform their tasks, how they look at their cohort of patients in terms of activity, and it's starting to drive change as the HACCs and the quality and safety work gets done. It's starting to drive change in that area as well, because that data is now in front of them potentially. And on the side, there's also been some recognition of the time they spend teaching and training.
And Ewan and Amanda?
I mean, it's made us one of the most efficient health systems in the world. And Christine, when in her talk on health reform, showed a couple of slides, one from OECD comparing us, the sort of matchstick slides with matchsticks up and down below the average. And in terms of efficiency, we have one of the most efficient healthcare systems in the world, driven principally through ABF and case mix. And, Victorians are the kings and queens of case mix. We'll get to the downsides in a minute, but it has, whether we like it or not, it's made us a very efficient system.
It's good to start on a positive
note.
Yeah,
absolutely.
Yeah. Amanda?
So first, disclaimer, I actually work in palliative care, which is ANSNAP funded, so I'll just be an ill-informed clinician speaking loudly and opinionatedly. But I've worked in the southwestern suburbs of Sydney with massive development and growth, and so we have a town the size of Dubbo, or Shepparton in Victorian terms, growing every 2 years within our catchment. And so for us, it means that funding doesn't just stay in the sandstones and the royals, it actually goes to where the people are and moves with the population. Maybe slowly, but it does eventually get there. And for me, that's a really good thing.
Kathy, your observations?
Yeah, look, I think that we've had pay for performance kind of incentives and penalties in the private sector for about a decade. So we're really very familiar with things like not being paid for sentinel events. That's been happening a lot longer in the private sector actually than in the public sector. And I was never, as a quality professional, as a clinician, I was never really involved in health fund negotiations or funding discussions. But I think it's really improved the discussion to have people who actually understand the quality and safety of care involved in those funding discussions. And that is a new thing, as the rest of the panel was saying.
Okay, so you've heard some of the benefits, and I'm sure there are many more that we could talk about. But let's also flip that around now and talk about the downsides. So what are the downsides or drawbacks to having activity-based funding? Should we start up the other end, Ewan? What are the downsides?
Well, at the core of all this, of course, are human beings. So we have a set of coders in our hospitals whose job it is to extract as much money out of our respective departments of health as possible. That's the way our system is built. I have to say, there's literature from elsewhere in the world looking at, highly regulated pay for activity systems and lesser regulated. I'm not suggesting that we're not compliant in Australia, and I think the error rates for coding are actually extremely low. At least they are in Victoria. I can't speak for other jurisdictions. Error rates are extremely low. But at the core of this is human behaviour, and there are perverse incentives in the system. So we're fueling activity, and we heard from Tanya, the Health Links talk from our own department here in Victoria. Health Links is trying to break away from driving activity, particularly driving more complex activity, to better meet the needs of patients. And she used the words in one of her slides, what matters to you? And we've lost the what matters to you from activity-based funding.
Alasdair, did you have some thoughts?
I think one of the things we've noticed is that there is a bit of misconception in particularly our medical fraternity, who those who work in the procedural and the and crossover between the fee-for-service and the public sector have this concept that activity-based funding is effectively de facto a fee-for-service model, and so instead of recognising that they are defined by a service agreement and how much service they're going to deliver over a period of time, they take the approach that if I'm being funded based on my activity, the more I do, the more the funding occurs. So it's taken quite a deal of time to unwrap the back of house process and see the process rolling over time intervals, rather than it being perceived as a sort of quasi fee-for-service process, which some of my colleagues certainly did when we first started.
And so you were saying to me earlier, Alasdair, that you felt that some doctors were very disillusioned with that system initially.
I think there was a real sense initially that this was not going to this was something that was foreign. We're a very change reverse profession, and in fact any change that we didn't think of ourselves, we're quite resistant to. And so in that context, there was this sense, and particularly once the HACC staff started to come on the horizon. There was a lot of pushback from my clinicians, actually, and from some of my administrators about this, and about given their perception of the quality of our data, that we were probably going to be seriously impeded by this sort of stuff. Yet, when you actually examine it, the quality of our data is actually quite good, and the frequency with which you're significantly penalised as a result of these issues. I mean, for sentinel events, it's it really, yes, I agree they shouldn't be funded, but at the end of the day, we would hope to only have, hopefully none. But so the implications for funding are actually very small for a big hospital, and so there was a sense that we were doing a lot of data, looking for a lot of data, reporting a lot of things, and without necessarily seeing a significant outcome from it. Partially because we're still effectively, although the health department is funded through ABF, we're still largely funded through a fixed budget for a period of time.
And so, Craig, when we spoke, you were saying one of the downsides that you felt to ABF was that it doesn't reward doing nothing.
Yes, one of the historical, for the elder people in the room that are familiar with the House of God, Law 13, says that the delivery of good quality healthcare is to do as much nothing as possible. Yeah. So pursuant to that, we identified a cohort of people who came in through the ED in medicine, stayed one night and went the next day, and because of bed pressures and a range of other things, we said, wouldn't it be better if we actually got the physicians to go to the ED, make sure which patients did need to come in, and so we very successfully got rid of about 700 which cost us $3.5 million. Thanks for that. So one of the challenges is you get what you count, and the system isn't quite good enough yet to pay you for what you didn't do, even if it costs you more money to not do it.
And Kathy, from your perspective, what have you seen as the downsides or the drawbacks to ABF?
So I'm going to just branch from directly just ABF, but the HACC funding in particular, while I think it's fantastic and it's really terrific, we have to be really careful that we're not losing the purpose for why we measure complications. So we don't measure complications for funding. That is not why we do it. And I think that if, and the clinicians can smell this a mile off, we don't go to their clinicians and say, we need to reduce our complications or we don't get paid. That is not going to motivate anybody. So you have to be really clear about your purpose. And I think if we start to lose that purpose, we all know why we measure complications, and the better we measure them, the more we can reduce them, and that's where my concern is here about that might creep in a bit.
So I've noticed that no one has asked a question yet in the app, so I want you to all get on the app, and not all, because we wouldn't have time for all of them, but if you be thinking about the questions, we've got some amazing panellists up here, and it's a really good opportunity for you to ask what you're interested in and your questions, because there will be time in the last 20 minutes for questions. And Amanda, when we spoke, one of the things you said to me was that people don't feel it's their responsibility to support activity-based funding. So what were you referring to there?
Often clinicians believe our primary responsibility is only to a patient and not to the system and not to fund the system. And yet I look at it as an opportunity to make sure that my patients get the funding that they need, and so being an outer metropolitan service with massive growth, the more that we can do to support and document what's happening for our patients so that we get the funding that will then support them through the future, that's actually really important to me. And when you were talking about the downside of ABF, one of the things that depressed me when it first came in was the realisation of how little my senior staff in my facility were actually oversighting what the junior doctors were documenting. And they left it completely in their hands and weren't actually making sure that what was documented was accurate, or that it was the whole picture.
And Craig, I think when we spoke, you mentioned something about that as well, about the problems with the junior doctors. Can you just let the audience know?
Yeah, identifying, we changed some of the terminology locally, and I have to a bit of a shout out to my medical record people in the room, yay. We changed the nomenclature and the terminology with the consent of the senior docs, that we stopped talking about coding errors. We actually now talk about documentation errors.
And why did you change that language? Why was that important?
Well, for two reasons. One is it's factually not correct, because when we repeatedly look at it, 70% of the time the documentation and the coding is correct. In the 30% when it's wrong, only 5% of that time is it a pure coding error. 20% of the time, it's just that the doctors, usually the juniors, didn't document it. So we wrote...
In the private sector, it's the senior doctors, I might say.
and they're much better. And so we're rather keen on the app, so we've already made a little note to roll out the app about the documentation. So thinking about that as looking at the whole 30%, it's actually about the documentation. And the analogy I sometimes use with our senior doctors, it's the coders are like your tax accountant. It's actually still your tax return.
It's only as good as the information that you give them.
Yeah. They're helping you. It's not the other way around. So, but being able to take it down, one of the tricks that we did was actually showing the doctors, particularly for the complications, every code for that patient, for every patient that had a complication. And for many of them, it was the first time they'd actually really looked at all of the codes. And we got two responses. One is, actually the data's better than everybody says it is, which was heartening. And the second one is that when it was an issue, and you pull the record out and they say, this person's clearly got diabetes, and you say, show me. And then they flick it through, and then there's a quick call to the junior saying, oi,
that they don't have diabetes.
How about you write it down?
Yep.
So that had a change for the better, to the extent that and documenting complications as being present on admission when they clearly were, and other things. We took our hospital-acquired complications from 3%, which is higher than the national average of 2%, down to 1%.
That's a great achievement.
And so the quality of the data, the reliability of the data improved. Interestingly, when it was high, the clinicians blamed the documentation. When it was low, they said, no, it was all them.
I love that idea too of you not blaming the coders, because we started collecting hospital-acquired complications at HealthScope, not for funding, but just for quality purposes. And all of a sudden, the poor coders and the poor health information managers, and I know you understand this, you get blamed for if we don't get enough funding from coding, and now, well, let's blame you for the quality not being right as well. So you're the meat in the sandwich here, and you've got to be really careful of the burnout of just putting all that pressure onto our coders and our health information managers who do feel the pressure, even though it's the documentation, it's not the coding.
So Ewan, I might just go to you, because we're talking now particularly about quality and safety. What are the key examples where ABF has really improved quality and safety in healthcare that you've noticed?
There aren't many standout examples of where ABF has improved quality and safety, and I think the journey that we're now on as a nation over the last couple of years around HACCs or central events or readmissions, whatever the levers are we're going to use. We mustn't lose sight of what the aim here. The aim is, I guess, what IHI would call a triple aim. It's about improving population health, improving care of the individual, and spending less dollars per episode of care where it's possible. And the challenge for us in a system that's fairly tight for money already is if we start withdrawing money from the system with the expectation that by withdrawing money we will drive improvement. I'm not sure there's skilled logic behind it. There are challenges there, and there are other ways of doing it. So VMIA, the public insurer in Victoria, last year rolled out an incentivisation scheme for maternity services in Victoria, where they gave them a discount on their liability fees, their indemnity fees. So for some of our big services, that's about $500,000 for some of our big maternity services. But you only get it if you invest that discount in improvements in your targeted improvements in your maternity services. And I think Victoria, we've activated central event pricing in Victoria. We haven't yet activated HACCs, and so I guess the state health department's wearing the costs currently. We need to be careful. I mean, there are lessons from the private sector. As Cathy says, the private sector have been doing it longer for us, although work that we did with just very quick look at work we did with Medibank a year or so ago suggested that there's a fall in HACCs across the system, about 14-15%, and that fall is present whether you're pricing or not.
And why was that fall? Why did it happen then if it wasn't to do with pricing?
Well, I'm not sure we understand. I mean, there are falls in HACCs across the globe. All systems who now collect measures of hospital-acquired complications, there is a fall. And again, some of it relates to the regulation of the system. So in the US, the lesser regulated services have seen a fall in HACCs, but they've seen an increase on present on admission complications. So suddenly, catheter-related UTIs have gone up on admission in patients who didn't have catheters. I mean, so one has to be careful in how one records that.
Do you think it's the Hawthorne effect, Ewan? We talked about that a bit earlier.
Well, it might be. Look, as Victoria's Safety Quality Improvement Agency, I'm loving that we've got to focus on HACCs. Just not completely convinced that withdrawing money from services is sufficient to drive improvement. And one of the real dangers, and Kathy's alluded to it already, HealthScope not measuring HACCs for funding, measuring HACCs for genuine improvement. But one of the challenges and one of the risks for us is a system that's built on HACCs. I mean, we've been rewarding HACCs up until now. As you withdraw that from the system, we'll just stop coding. So we'll undercode now. So we will see a fall in HACCs. Are our patients safer and better because of it? Not sure.
So in other words, you don't want to just have people playing the system if that's the situation.
Yeah, and I think playing the system's one way of putting it. There's no malevolence here. We've got very smart people at all levels of our system trying to do the best possible for their service, for their patients, for the system more broadly. So this isn't game playing for the sake of trying to pull one over the department. I like to think that's the case. But we just need to be careful of what might be the perverse outcomes from some of these levers as we pull them.
Amanda, do you have some thoughts?
From my point of view, we're not there yet, but the best opportunity that the HACCs and this body of work provides is actually getting data back to the clinicians. Because otherwise, we all think we're doing reasonably well most of the time, and it's only when you're confronted with good, hard data that demonstrates that you're doing really well in this space, but actually, here's an opportunity to do something. And so the better we get at feedback loops where clinicians get information about their performance, and we'll have a grief response when we get it, and we'll deny it, and we'll be a bit pissed off and say the data's wrong, and that kind of thing, and then we'll bargain and try and include and exclude things. But eventually, if you get to a space of acceptance, okay, I've got a problem with this, what can I do about it? That's when we're really cooking with gas.
Do you think that data, I was interested in Andrew Street's presentation where he showed in the UK the access that patients can have to really transparent data about clinicians and their outcomes. And do you think that sort of system would ever be introduced in Australia? And if it was, what difference would it make?
I think it will. Will we have individual clinician outcomes? For sure we will. I mean, many of our colleges, probably including my own college, certainly the College of Surgeons, would deny it today. Well, they're living in cloud cuckoo land. Of course we'll have individual clinician reported outcomes. I'm not sure. I mean, I missed Andrew's presentation and was talking to James about it, but the jury's still out whether patients use that, but clinicians use it. Yeah. So I would hate to think,
Well, in terms of who they refer to, or like refer patients onto, or
no, well, both that, but also I don't like to think that Amanda's a better clinician than I am. So if her outcomes look better than mine,
and I'm in palliative care.
If her outcomes look better than mine, and we were in the same craft group, which we're not, we're at polar ends. But then I think so. There is evidence that clinicians change their practice,
exactly. And that mortality reduces.
Yes. Yeah.
So we've got a wonderful study that came out a couple of years ago now from the UK that just shows was it colorectal surgery, and the mortality rate drops as soon as you publicly report individual clinician data. It's magic. It's my favourite study of the last 2 years, you can tell.
And it's certainly naive to suggest that that now that this data exists, that it's not going to end up in the public sector, so that the healthcare consumers can look at it. And to come back to the point that Ewan was making, I think there are potential perverse or unintended consequences of some of these processes, and particularly some of the HACCs. And that's, that's clearly one of the important roles that the IHACPA plays, and that's clinical advice, is to monitor those unintended consequences. I mean, a good example might be that if we look at the ongoing role of potential readmission data, that we might, for instance, see problems with prolonged length of stay for patients, particularly with fragile cardiac problems, because of the implications of an early readmission, where we may, in an environment where we're under pressure to discharge, that may change practice. Now, it may change practice for the better, but it may change practice for the worse, given that prolonging length of stay of almost anybody is associated with further complications.
Craig?
I look at it, because I completely agree, but I also look at it from the point of view of why would you hide your data? Because when you have a Bundaberg, when you have a Mid-Staffordshire, when you have any disaster that comes out, the data is in the public domain. So wouldn't it be much, much better to get it out while you're controlling and looking at it in a civilised way, rather than waiting until the disaster happens? So that's point number one. Point number two is, whilst I've been very enthusiastic about having HACCs being so visible and looking at that, there has been a slight counterpoint, and that is that the remainder of the complications have been defocused. All of the stuff coming out of Mid-Staffordshire, the King's Fund, the stuff that Duckett writes about, all of that says you must look at all of your complications.
So you need the big picture, not just focusing on one part.
And the wonderful thing that HACCs did was it got the finance department and the reporting people very interested in this. But I actually had a hard job getting them to say, yes, but can you give me all the others as well? Oh no, we're only interested in HACCs. Yeah. So it's actually time now, I think, to move to that all complications, because and it's easy to be depressed about that, because whilst the rate hasn't gone down, the volume of patients going through our facilities has gone up. In my lifetime, length of stay has gone from 10 days to 2 days. The complexity and the number of comorbidities of patients has gone up enormously, and the coding staff are assiduously looking for every possible complication. So in that environment, for the complication rate to remain steady is a marvellous achievement.
That's a very good point. Ewan, did you have and Amanda?
I agree with Craig. I think it's due to IHACPA's credit that we have been very cautious in the HACCs that we have launched. And as they were being built, I was badgering James to have severe perineal trauma as one of the HACCs, and IHACPA just couldn't risk adjust it adequately to make it saleable to the sector. And I think that was right and proper. But what it has done now is got us into a reporting mentality that, and I agree with Craig, we should report all HACCs. Whether we price for them all is another matter, but at least we could report them. In terms of individual clinicians, and we will get there, but there are some serious and important anxieties, and the general surgeons would say, well, one of the challenges for us is that our young surgeons are the surgeons who are staffing overnight and doing emergency laparotomies, and mortality and complication rates are much higher for emergency procedures than they are for a cold elective surgery. And so how do we correct for that? Because you don't want to contaminate a young surgeon's career as she starts out in her career just because she's staffing the on-call emergency laparotomies. But the minds that are in this room and the minds that are elsewhere in the country, we can risk adjust those things. And I think we just need to get on this progressive public reporting, transparent data road, and the sky will not fall in on us.
Amanda?
Yeah, and kind of transparent public reporting will change the behaviour of some people. But to follow up on Craig's comment about inquiries, the reason I'm interested in safety and quality was because 3 months into my first staff specialist job at Camden Hospital, you may well be familiar with Camden and Campbelltown hospitals, the proverbial hit the fan. And what amazed me through living through all of that was how many people did not drive past our hospitals to go further up the road. They came because they were sick and desperately ill and they needed help. And so even in the face of public reporting, there will be a lot of people who just need help and they need it locally and they will still turn up. So it will change some people's behaviour, but the sickest and the most vulnerable will still be there.
Kathy, Sophie, did you have anything to add before we move on?
I think I just wanted to just mention that when you look at a reduction in HACC, so Craig was talking about a reduction, we've had a reduction at HealthScope as well over 2 years. Is it just data? Is it just better quality data? And in the end, it doesn't really matter. Now we know, because if you get rid of all that noise of incorrect data and incorrect clinical documentation causing errors in coding or whatever the case may be, you can actually pinpoint the real issues, because you can find the hacks that actually are preventable if you get rid of all of the other stuff. And so even if we are just getting rid of all of the data issues at the moment,
Even
that is
that's a
so
good thing.
valuable.
Yeah.
It's incredibly valuable.
Even that's a good thing. We might move on to some questions from the app. We've had heaps of questions flying in, so that's really good. So the first question is from Natalie Bryant, and she asks, we often hear that ABF incentives inpatient care. Does funding truly influence a clinician's decision where to treat a patient? So who'd like to have a stab at that one?
Yes, but not often, sometimes not of their own making. So oncology is a classic case in point. Massive administrative change. Must be outpatient, must be inpatient, then back to outpatient. It depends on the flavour of the month. Are we after CMBS revenue, or are we after WOW? So that changes that setting. I don't know that it changes the clinical care at all. It changed a tick in a box on a computer in that particular example. There are other examples where I think it has, and I'm sure the others have got examples.
Alasdair?
I think I agree with what you're saying, but I disagree in that I don't think it impacts the decisions clinicians make. I think what you find is that these are institutional decisions based on an institutional approach to things like oncology, like dialysis, these sort of things that can be inpatient or outpatient delivered care, and then depending on other factors, there are a whole stream of other things that can potentially be things. So I think clinicians make decisions not on financial basis. I think you've only got to look at the expensive treatments that clinicians are happy to offer to know that the dollars aren't driving those decisions.
So Ewan, did you have some thoughts?
I mean, what it does do, I think, goes back to some of the comments that Christine talked about in her reform slides, is it gets in the way of preventative measures. And one of the things that programs like HealthLinks and others, it allows opportunities to put preventative community-based measures in place that will reduce hospitalisation usage. And activity, and it's not activity-based funding per se. It's that, but it's also our structural funding divide between Commonwealth and state, and commentators on funding reform often cite Canterbury. Canterbury had to; they were forced to make fundamental reform. We have two payers here, and the attraction of some of the reforms that Christine talked about, and the examples that HealthLinks and other systems give us is actually it's about breaking down the structural barriers to funding that are getting in the way of place of care.
Anyone else want to comment on that before we move on? We've got quite a few questions, so I want to get through as many as I can. We might just talk for a minute about value-based funding, and one of the questions we wanted to cover was how do we make the future directions of value-based funding a reality for clinicians? Who would like to? Alasdair?
Oh, I mean, I think value-based funding is already something is changing models of care uniformly, not just in Australia but overseas. And I'll give you a personal example. And it won't be unfamiliar to almost everybody in the room. But I've got a son who's a physio, and he worked in the NHS for a number of years. And where he, in a musculoskeletal outpatient environment, was the gatekeeper for MRI, was the gatekeeper for referral to orthopaedics. So you had to go through a physio with your musculoskeletal problem before you could get those sort of investigations performed. And he's come back to our jurisdiction and is running a similar program. I know those sort of but hasn't got the levers to be the gatekeeper for referral.
Ewan, did you have any thoughts about that, about how do we make the future directions of value-based funding a reality for clinicians?
I mean, I think it is about co-design, isn't it? It's about having patients and clinicians involved in the planning of changing how we do it. And the physio gatekeeper example for orthopaedics, musculoskeletal is the sort of archetypal example of changing. If the entry point to the system is you see an orthopaedic surgeon, well, we train our orthopaedic surgeons to do operations. You will have an operation.
Yep.
The Commission, publishes atlases of variation.
Yep.
They're a gold mine of saying, here's where we should go for value-based healthcare initiatives. In my own discipline, we have a 7-fold variation across the state of Victoria in hysterectomy rates.
Yep.
Why is that? Well, because if you get sent to a gynaecologist, we train a gynaecologist to do hysterectomies.
That's
She
what
will
they
take
do.
your uterus out. Yeah.
Yeah.
So it's about changing, but don't impose a change system on our workforce or on our consumers. Involve them in the design of the change.
I think it's the same as we've been saying earlier. It's the transparency. No clinician that I know wants to be the outlier.
Yeah. Exactly. We'll just go to a question for the app, which sort of follows on to transparency. James Downey is asking, he'd be interested in Ewan's view of the value of benchmarking things like HACC rates, and we talked about making individual doctors' rates public, but should there be public reporting of health-associated complications, hospital-associated complications?
Well, I think there should. I'm anxious a wee bit about benchmarking per se in the first instance.
Why is that? Yeah.
Well, because the industry is very complex, and it would depend on how we were able to risk adjust. And again, I agree with Craig's point. While IHACPA have confidence, and we have confidence in the risk adjustment of the HACCs that we're pricing for, let's not limit our public reporting just to those HACCs. And so, if we can't risk adjust for the others quite as confidently as we have for the list that we're pricing for, we just need to take that into account. Do we want a My Schools equivalent for our hospitals? Maybe we do. I just don't think the system has the confidence yet to do that. Will we get to a place where we're benchmarking either formally, probably. In the first instance, it will be informal. It will be my hospital looking up the road to the hospital up the road saying, well, they look a bit better for these disciplines and a bit worse, and why is that? But if we could get our hospitals talking to each other, what have you done to reduce that HACC?
So they can learn from others' experience.
So public reporting, absolutely. I mean, our view at Safer Care Victoria is we should these data belong to our citizens, and they should be going back into the hands of our citizens.
Amanda?
And I think one of the challenges with some of the HACCs is that some of them, for example, delirium or perineal tears, if you're providing an excellent model of care where you're screening for the presence of delirium repeatedly during an admission, you are much more likely to find it. And so potentially the centres of excellence with fantastic care will have a higher rate and look worse, and actually it's because they're better. In the same way with perineal tears, if you just eyeball, you may not find every perineal tear, but if you examine, you may. And so the centres that are providing good care may actually perversely
questions and looking for things, they'll find them.
Look worse.
Does anyone in the audience have questions? If you do, please raise your hand and we'll try to get a microphone round to you. So anyone in the audience like to ask a question? Otherwise, I'll just keep going. Yeah, we've got one up the back. While we get there, I'll just ask, I'll ask another question from the app. So Wendy asks, do the clinicians have an opinion on the view that we are not yet publicly reporting on quality clinical outcomes because the financial agenda has been overshadowing the quality and safety agenda? Should safety inform the funding? So who'd like to have a go at that?
Safety should always inform the funding, and as Ewan says, the question is how.
How?
So the principle is a no-brainer, but it's the challenge of how do you do it without completely scaring everybody on the first round. I often wonder about these things and say, well, what we should do is collect everybody's complications for publishing in 2 years' time, but if you make an improvement, we won't publish the bad stuff. So there's a time frame for publishing.
So put it in a time capsule and say, let's look at it in 2 years'
But if you've
time.
made the improvement because your data wasn't good or whatever the excuse was, or we got better normalisation, then we won't publish the bad historical stuff. But you've got to, whether it's 2 years or 5, it actually probably doesn't matter. But you've got to start somewhere.
Yeah. Amanda, and then we'll go to a question from the floor in a minute.
And I still think the first step is getting that data back to clinicians first.
Yeah.
I'd prefer to learn about it myself than read it in the paper. and then have to address it. So,
Or on the 7:30 or something.
Yeah.
No, so I'm
If you've
I'm
got
not
any
sure
stories for 7:30, though, get in touch.
So I'm
But
not
she'll be
sure
nice.
I completely agree with Kate, because, and I share the anxiety, and I feel the anxiety, as a clinician, but then we're hiding from the fundamental driver to improvement, and this is what, and I know it's a tiresome comparison, but this is what aviation learned a long time ago, and it's nothing to do with that they're just flying metal tubes. It's a culture. They've solved the culture piece, and we haven't solved that. And that will be the solution to better safety.
And so what are those steps to change that culture? I mean, it's a big question, but...
Just make everything transparent. But not have a punitive response.
So not
to...
sticks.
So when harm happens, you don't sack the nurse or
Yeah.
sack the physio or sack the surgeon or whatever. It's understanding why did the harm happen. It's very rarely an individual. It's usually the system. And even more rarely is there malevolence, intended harm. That is, exceptionally uncommon. And yet our whole behaviours are built around, and not uniquely medical behaviours, but the most evident in medical behaviours, our whole behaviours are around, you made a mistake, you have to answer for that. Well, you can't begin to improve if that's the starting
The
point.
attitude, Alasdair, and then we'll go to our question in the audience.
I think we also need to recognise, to go to the question a bit, that it wasn't until funding came part of this process that the investment in getting the quality data and the recognition of the manpower that was required to do that, and suddenly having good coders was the most important thing a hospital could do. That's what drove this. Once the data's there, I don't think there's any doubt that the safety agenda will change culture.
So what Alasdair's saying, I think, and I agree with you, it was a necessary evil to get through that. It was the catalyst to get us over. But now that we've matured, now's the time to continue on to broaden
And embed the culture.
Yeah.
We might just go to our question from the audience. If you could just stand up and identify where you're from as well.
Raghul from Swan Hill District Health. It's a common question, even though it's on Safer Care Victoria as well. When health services made a recommendation to improve resources for patient safety reasons, this particular funding model doesn't cater for those resource requirement. I would like to get comments from the panel, including Professor Ewan Wallace. Thank you.
You first.
Thank you. I mean, we were just chatting at lunch. Amanda and I were just chatting at lunch actually about. Amanda was asking me what's been the most surprising thing in being involved in safer care. So, those of you who are visiting us from interstate, we're just two years old. Safety agency, 2 years old. In response to Stephen Duckett's review of our public hospital governance system. The most surprising thing for me, one of the most surprising things for me is great pleasure and privilege to visit our hospitals and our health services and then find, whether they're from RCAs or system reviews, find recommendations that in some cases are years old and the board doesn't have visibility. So in Victoria we have 84 health services, 84 boards. The board and the board chair is ultimately responsible for those recommendations. And the lack of line of sight at the board level about recommendations. And again, it goes back to culture. Recommendations are made by an RCA, review committee. Maybe they're a bit hidden from the coup or from the CEO because they've got funding input, and they're hidden again. It's a culture thing. And so what struck me is not that there's not money to make the recommendation, but rather the hospital itself often, as an institution, hasn't invested in the process and it doesn't feel it own. The recommendation lives in the quality office down the corridor. They've made the recommendation, doesn't belong to us. Does that answer your... Doesn't really answer your question at all. I'm interested in the views of the others.
Yeah, who else would like to comment on that issue about culture being an issue and the quality, staying with the quality officer not pervading through the whole culture of an organisation or a hospital.
Oh, absolutely. So we collect HACCs in my organisation because the board puts a massive priority on this. And I think that you can incentivise, you know, complications all you like with money, but unless your CEO and your board are talking about complications and patient outcomes, and then the quality data will remain with some poor bugger who has to deal with it, because there isn't anyone senior enough to really drive it throughout the organisation. So it's start with why. Why are we collecting this? Why do we want to know? Why is this important? And then everything else follows from that purpose, basically.
And so having that top-down approach that you just explained, what difference has that made in your organisation to HACC rates, do you think, having the board really engaged with that as an issue?
It is the major factor. So we don't have any financial penalties in our organisation for HACCs. You don't need financial penalties to make an impact on this. It does help if you have a board or CEO that isn't so interested. It does help, and I think it's really positive to have a financial penalty or bonus attached, but you don't need it. So everyone is driven by the same purpose, to reduce complications, to improve safety, to improve quality. And if you have your leaders talking about it, it makes a massive difference. It is everything, actually.
And is that reflected in your experience, Amanda and Alasdair, in the public system?
I mean, I think in my experience, you know, the ownership of recommendations, you know, if they're cost neutral, is taken on by the by the departments that have been involved. But once they become anything but cost neutral, even though in the long term any intervention of this nature is actually going to be is actually going to be positive in your bottom line. In the public sector, and certainly in the jurisdiction that I work in, there's a clear distraction that the political agenda overrides sometimes the agenda of the organisational administration.
Yeah. Amanda, do you have some thoughts?
Just Ewan was mentioning governance, and I think one of the challenges still in Australia today is that corporate governance often trumps clinical governance. And actually clinical governance, a shared responsibility to provide the best patient care, should actually drive everything, including our corporate governance.
And how do you embed that? How do you embed that as a principle?
That's really challenging.
I think so. Again, the Victorians in the audience will be familiar. So Safer Care, last year we signed a 4-year partnership with the Institute of Healthcare Improvement in Boston, so IHI. And last November, December, they published a white paper on clinical governance. And I was a bit annoyed because we'd published ours the year before, and if I knew theirs was coming, we would have held ours. But
no, yours is better, Ewan.
Because they flipped theirs to have the patient. So instead of talking about safety, they talk about keep me safe.
Yeah.
You know? And so I think actually, as we've talked with boards through our board governance, our clinical governance training, everyone gets it, but it needs said. Yeah. So I don't think it's a difficult journey, but it is about actually you own this, and and again, there is a possibility that our insurers won't indemnify you if there is a clear governance failure, and that's sometimes missed. Yeah. But no one argues with it. So I quite like the IHI's flipping and putting the patient, the consumer, right in the middle.
Yeah. Now we've got a couple of minutes left. If you do have a question, just please raise your hand and we'll run a microphone over. Do we have any other? Got a follow-up question there? Any other questions? We've got a question here, so we'll just run the microphone to this gentleman here. Thank you.
Thank you very much. Really enjoying this discussion. So we've had a fairly close focus on safety and some of the issues around how we address that. I wonder if the panel could reflect on how outcomes, the broader set of outcomes and value for patients could be brought into the funding framework. I'd be interested in your ideas about how that might happen.
Okay, who would like to have a Craig?
Yeah, the first thing is to measure it and to have it available. I would love to have the conversations with our clinicians who would equally love to have that but we just don't collect the data. So if you don't collect it, it's not going to happen. I mean, we should just kind of make a decision, we're going to do it, and that's
Just make it routine.
Make it routine, yeah. Not a question of a sample population, everyone every time. And it has to be very simple. It's got to be like the Uber app, you know, the star rating when you get out of the cab. It's got to be that simple, because you don't know when you're doing your analysis how small the sample size is going to become that you then want to have that data. So it should just be routine. I mean, I think it's a no-brainer.
And Amanda, we are starting to do that in New South Wales, aren't we, to do more of that?
Yeah. So there's been a lot more work in patient-reported outcome measures in that space, and some of it at the national level as well, starting to build that up. But again, there's a way to go.
Yeah, but and how easy would it be to make it, like what Craig says, just make it routine? Again, is it that culture shift that you just make it something that everyone does?
Just somebody needs to say you don't get any funding if you don't put it in your data set.
Yeah.
No, then we'll end up with 20 different methods of measuring it.
Yeah, but it's got to be the one it. That's exactly, that's what I'm saying. So it's got to be the
having it
decision
simple,
about
like an Uber app or like a rating system, really to keep it as simple as possible. Ewan, what do you think?
Yeah, it's the next wave, isn't it? It's the next change. And again, I'm sorry I missed Andrew's talk earlier today. It has to be the next thing. And I agree with Craig. It should be just part of the administrative data set should be how does the consumer rate the outcome? What matters to the person, and was it a good outcome for you or not? And I agree, we have to collect the data first, and then report it, and then work out as we do that how do we influence funding for the care that we provide? Because we've lost, and I can't remember, it might have been Christine, we've lost care from healthcare, and so that's how you bring it back.
I would like, sorry.
No, go Craig.
One of my passions is, as a medical administrator, I get to read the history of every person who dies, to determine whether there's been an issue and things, and it drives me to despair when I read the chart and the chart says all cares given with an S on the end, and I want to ban the S on the end of the word cares, because I don't want my patient to get cares. I want my patients to get care. And we've stopped that, and this is why I think it's really important that we actually ask people, were you cared for?
Excellent. And I think that would really inform the discussion going forward, to put the patient at the centre of everything that we do. So look, we've run out of time, unfortunately, so please give a big round of applause to our panellists.